respected professors and senior colleagues and junior colleagues and my gurus, our sir, Evachari sir on the stage, and I'm hereby going for this topic of perianal abscess, do's and don'ts. Is it required to do a fistulotomy, or is it advisable at the time of draining the abscess or not? So we are going to have a discussion. I am Dr. Raghu Racha from Nagar Karnool Medical College, Professor and HOD. Thanks for giving me an opportunity to Dr. Pallam Praveen, who is organizing this FistulaCon 2025. Yeah, as you know, the perianal abscess, there is an infection of the soft tissue which is surrounding the anal canal and rectum with the formation of the abscess cavity. So mostly you know the incidence where it will be more common in the immunocompromised individuals, where diabetes and immune suppressed individuals, and more common in the third to the fourth decade and also seen in the fifth decade of and males are more predominant because of their the hairy region and the perianal the environment. So coming to this etiology, you will be knowing non-specific infection of cryptogranular, which is the non-specific infection, and the secondary causes where the Crohn's and ulcerative colitis, the TB, where you have the multiple fistulas, actinomycosis, and underlying carcinoma, and wherever there is a trauma or infection, secondary infection which leading to, and in the foreign body, and other inflammations and other leukemic conditions, you will see this fistulous formation and abscess cavity. So coming to this perianal space where the abscess cavity, and you can easily differentiate with this picture where the supralevator space above the external sphincter, and coming to the tissue-rectal space, which is in a higher, and intersphincteric space also, and lining the mucosa, there is a submucous space, and you have the perianal space, which is quite common where the anal gland infection which drains towards the skin, where you can see this perianal abscess. And coming to the higher spaces where like pre-sacral space or supralevator space and deep post-anal space also, you can see such abscess cavities which are there at higher levels. And this is all above the puborectalis also, and you can see the adjacent figure where you can see these abscess cavities above your sphincters and even the puborectalis. So what to do then? So how do you work up, and what investigations, and how do you manage? That was the question. So usually you won't have any specific test until unless they have been you have an underlying diseases. You need to control that. For example, they are diabetic, then you need to control the diabetes, and definitely that will be the causative cause for that, and immunosuppression will further needs an evaluation. And imaging role comes in only deep-seated abscess, where you have to pertain the patient for this anal ultrasonograph and MRI fistulogram, and CT. So as usual, you will be knowing once you do a blood picture and profile of that, you will see the differential count and leukocytosis will be seen in the pus culture. So what is that? Mainly is it's in a surgical where a small abscess will be dealt with the antibiotics, but once it is more than 5 centimeter or more in the fluctuation in the sense where you have to go for an incision. This management depends on the infection, underlying infection, the tissue destruction, and there is every chance of sphincter dysfunction if you doesn't drain the abscess. It will further extend into the other spaces, which you have to prevent it as early as early intervention is required to prevent the further fistulous formation, because pus anywhere it will try to spread. So from the deeper tissues may involve, and the fat necrosis will be there. Further the extension of the pus will take in its own course from extrasphincteric to transsphincteric and supralevator spaces also, and rectal forces. For that you need to immediately attend it. And nowadays, previously we used to do a small incision on the fluctuations, area of fluctuation in close proximity to the anal verge, a small cruciate incision. Nowadays the technology is, now we have to even go for a radial incision also, and the pus is sent for the culture. The hemostasis is achieved by the manual pressure, and the wound is packed. More pressure is not required in wound packing, because there will be excruciating pain will be there. The pack will be taken out of 24 hours and you need to irrigate it, and but more of bigger package is not required. At the same time, the localize also you need to break, but if it is historectal fossa, you need not to go deeper, not to injure the things. So, and better is to do with an suction. Previously we used to break the loculi with the finger. So previous method of learning is to take out everything, but here you should not damage more the tissues. So whatever the pus, you need to take it out through the tip of your little finger, and then minimize your destruction of the tissues over there. So that is most important. And the gauze is removed after 24 hours. Now cruciate incision. Previously we used to take a cruciate incision. Now there is a simple radial incision. Take a suction and then take out the pus, whatever the collected in the abscess cavity. And whether to identify the fistula is not, will discuss. And this is a drainage of the perianal abscess, where you can do things. The scarring of the cruciate incision, for example, if you give a big cruciate incision, take out a little amount of pus which is of 5 ml, less than 5 ml, and then the scarring will be an ugly scar will be there. So to prevent that, you need to do a radial incision. Nowadays we are going in favor, nowadays the new school of teaching is, you have to give a minimal incision, take out entire thing, and then put a gauze over there, irrigate it, and then come out and plan for the further surgery. And you have to tell the patient, if it is a prolonged abscess cavity, then there is a second surgery where he need to evaluate for the fistula. So only the abscess cavity, the duration of abscess cavity is also very much important, and how we are treating. Like for example, the doctors until like RMPs, where they will be giving prolonged antibiotics, and then the duration of the abscess cavity will be prolonged, and there will be already established fistula will be there. So you will be dealing only with the abscess rather than going to the fistula. So your main aim is initially to drain the abscess, and then counsel the patient that he needs further evaluation with the endoanal anal ultrasound to identify the fistula, and there will be a chance of second surgery also. You need to counsel. So perianal abscess, so perianal abscess you can classify like ischioanal and ischiorectal, where it is in an intersphincteric and a transsphincteric. And ischiorectal, there is an intersphincteric, transsphincteric and suprasphincteric and extrasphincteric. So how they have been dealt in the coming slides. The group 1 where intersphincteric and transsphincteric, if it is a concealed abscess without any rupture and without internal and external opening, or without internal and external opening. Whereas another group is intersphincteric ruptured abscess with internal and external opening, In that, the treatment in the first group, without internal opening, only the abscess is there. The drainage of abscess is towards your anal canal to prevent the fistulous formation. Whereas it is a transsphincteric, it is away from the anal canal you need to do, so that you won't injure your sphincters. And coming to the second group, where is it in a ruptured, you need to, along with the tract, you need to take out the fistula tract, fistulotomy, that is opening of the fistulotomy for both intersphincteric and transsphincteric. So coming to the high anal, where there is, now previously we have dealt with ischioanal, now we are going in the high anal, where ischiorectal, once again there is a concealed abscess and a ruptured abscess. Ruptured abscess is where there is a fistulous tract. So here, without internal and external opening, that is intersphincteric, transsphincteric and suprasphincteric, where you can deal with an internal drainage, and transsphincteric is an external drainage, and suprasphincteric is internal drainage, and extrasphincteric is external drainage. So, and whereas coming to the rupture, ischiorectal is a higher one, where there will be a chances of injuring during the debridement. You have to be very careful in dealing with that, because there is every chance of dealing with the internal sphincter, where you may land up in the flatus incontinence, and recurrence of fistula will be more. So you have to be very careful in the high anal ischiorectal fossa, especially when the abscess is there in the ischiorectal, where it leads to its ramifications, where you have to identify, properly plan out, and then deal with that ischiorectal fossa. If it is a higher, where this 1 and 2 you can easily near to the anal canal you can do it, but when it is in a high fistula, you need to properly plan for that and then take out entire abscess cavity with the fistula. The same thing where the intersphincteric is primary fistulotomy from internal opening to the intersphincteric groove, or closure of internal opening and intersphincteric groove. Transsphincteric is external drainage and sit-on placement and proximal fistulotomy. And before that, you need to define the fistula. You have with the moderate investigations like MRI, fistulography, and endoanal ultrasound. You need to see whether it has really crossed the sphincter, or it is more upper one, or it is where it is. You need to define, and you should know the anatomy in a proper, and then deal with the fistulous tract. Otherwise, there will be every chance of recurrence will be there. Do not manage conservatively if the abscess cavity is large and fluctuant. Do not drain without doing any coagulation. There will be more of bleeding will be there, and do not drain away from the anal verge. So if the internal opening is near to that, and better to open into the anal canal. If drained away from the anal verge and fistula develops after surgery, there is high chance of sphincter dysfunction. So there is your external sphincter dysfunction will be there, but internal sphincter, you need to be very careful with that. Is primary fistulotomy is advisable? Performing a primary fistulotomy at the index drainage procedure remains controversial. Some argue that no attempt should be made to look for a fistula, as the surrounding information makes it difficult to identify track and creating a false passage. Additionally, many abscess drainage procedures are done by trainees and the surgeons without specific colorectal training, and so one viewpoint is that they should be kept as simple as to avoid iatrogenic injury more. So in the larger series of 1,000 patients where primary fistulotomy was performed, 7% of patients there is a short-term change in anal function, and 3% at the after observing after 2 years. So these studies are support, and in review of 15 cases of patients with anorectal abscess who had a fistula identified and underwent primary fistulotomy, no recurrences were observed, but 17% had a difficulty controlling flatus post-operatively. So there is variations like how do, and at 3 years there is an impaired flatus control, while 4% of reported fecal leakage. So another study showed that the patients treated with primary fistulotomy subsequently had a severe incontinence, because to identify and without defining, without diagnosing properly the fistulous tract, if you drain and then try to take out the tract or try to open the fistula, fistulotomy, then you will be damaging more. So you need to plan it a proper way. What I mean to tell is, this was attributed to laying open of a fistula that was mistaken classified low transmission. This group recommended that if a fistula was identified, then a loose seton can be placed to reduce the risk of sphincter damage. Others argued that primary fistulotomy is an appropriate treatment if an internal opening is identified and the fistula is suitable for division, as it leads to a very low incidence recurrence rate. So with the proper patient selection, several small randomized trials have shown positive results with the primary fistulotomy. There are 28 individuals in the incision drainage group and 24 in the fistulotomy group. At the 1 year follow-up, 25% of the incision drainage group had developed a fistula. None of the patients in the fistulotomy group developed a fistula. So there was no changes in incontinence in between two groups. Interestingly, this study this was taken from the various studies. Interestingly, the study included anal manometry performed just before 6 weeks and 3 months after surgery, and is not significantly different between two groups. At 1 year follow-up, one patient who had undergone fistulotomy had an anal stricture, and large randomized study of 200 patients published in 2003 showed a similar findings. So despite these favorable outcomes following fistulotomy, an anal fistula occurs at 50% of the time following drainage of anorectal abscess. All of the patients never had an additional problem, and these are all the abscess needs to be drained and continence should be preserved. Risk of recurrence will be low. This is the German guidelines S3. Primary fistulotomy should be done by experienced surgeon only. In case of unclear findings, need to do in a repair in the second sitting. So recurrence rates of abscess along drain group was 88% when compared with the abscess plus fistulotomy. So when this published in 2013, this says recurrence rates abscess alone drained is 88%, and when compared with the abscess with fistulotomy is 4.8%. Here shows that fistulotomy is the safe but in experienced hands. So for majority of the intersphincteric and perianal abscess, primary fistulotomy should be the first choice, and hysterectal abscess rarely cured by one-stage procedure. This is a complicated one, you need to deal it properly. And these trials also shows that drainage of anal abscess with fistulotomy can be safely performed in case of subcutaneous, intersphincteral and low transparental fistulas. However, drainage alone and posterior treatment of fistula tract is recommended for high transsphincteric and suprasphincteric fistulas. So these are all randomized trials previously, how they are dealt with. So the take home message is all the abscess need to be drained, and it is not necessary to tackle the